All right, welcome everyone to our webinar today on supporting youth with addictions, organized by the Center for Innovation in Campus Mental Health. We are joined today by our two presenters, Jane Hopkins and Ellen Chang. Just a note, participants are muted on the call. You are in listen-only mode. We will be taking questions at the end of our webinar, so please use the chat function or the question function to type in your questions, and we will take them up at the end of our webinar. This webinar is being recorded, and we will make this webinar available on our website at campusmentalhealth.ca under the webinar archive section. We will also have a short survey that you can complete after the webinar, so please take a couple minutes to give us your feedback. We always find that very useful. I'm going to start off by introducing myself. My name is Shafiqullah Aziz. I'm the Stakeholder Engagement and Communications Coordinator for the Center for Innovation in Campus Mental Health. Our first presenter today is Jane Hopkins, and she is a policy analyst and lead on the complex care and addictions within the Canadian Mental Health Association Ontario Division. Jane's background includes studying international drug policy with McMaster University's Global Health Program, and she has previously worked as a social worker in community-based addictions treatment with women and their families. And welcome, Jane. Our second presenter is Ellen Chang. Ellen Chang is an addictions therapist on the Family and Youth Initiatives team at Breakaway Addiction Services. And Ellen specializes in providing counseling to youth with substance issues as well as their families. Thank you both for joining us today.
Thank you. Thanks, Shafiq.
Great. And so at this point, I'll turn it over to you two, and you can go ahead.
Great. Thank you very much. Yeah, as you mentioned, my name is Jane Hopkins. I'm with the Canadian Mental Health Association Ontario Division. So for the webinar today, we're going to be exploring some of the topics with substance use in youth. There's a lot of content in this webinar and a lot to discuss in a very short period of time. So as mentioned, there will be questions towards the end. However, if we don't get to your question, or if there's anything that you feel would be helpful to discuss or share later, then please feel free to email either one of us at the email provided on this slide here. So I'm just going to jump in here and discuss terminology for a few moments. So addiction is often used in the term addiction is often used in a very general way, but it's important to consider that individuals who might use drugs or alcohol in a problematic way might not necessarily be addicted. So I'll be using the terms addiction and substance misuse throughout the webinar, but both have very specific meanings. So addiction is the physical and psychological dependence to a substance or an activity, despite the potential harms. So this can include increased tolerance or the need for more of a substance to attain the desired effect, as well as withdrawal symptoms as well. Substance misuse is when a person experiences negative consequences from certain behaviors or substances. So this refers to people who use substances in a problematic way, but might not necessarily be addicted, and we'll discuss this a little bit more throughout the webinar today. So for example, someone who maybe went out and had an evening of binge drinking on a Friday night, woke up on Saturday, had a bit of a hangover, is somebody who misused substances. So these are people, this is a person maybe who is using a substance in a problematic way that could potentially lead to psychological or physical dependence, but they're not necessarily addicted. Substance use disorder is a term used by the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5. So the DSM outlines 22 different criteria for a diagnosis of substance use disorder, and that can range from mild, moderate, and severe. Typically, I use the 4 C's to identify when substance use has become problematic for someone. So the 4 C's include craving, loss of control or amount or a frequency of use, compulsion to use, as well as continued use despite negative consequences. So for the purposes of this webinar, we're going to be focusing on the use of substances, but it's also important to acknowledge process addictions or behavioral addictions, such as gambling, internet addiction, hoarding. Currently, gambling is the only process addiction that's in the DSM right now. I think it's also important to provide some context and to provide some statistics around youth and substance use in Canada as well. So alcohol and cannabis are substances that are most frequently used by youth, and Canada ranks among the leading countries for rates of both prevalence and frequency of these substances for young people. We also know that in Ontario, there's been an increase in the rates of problematic opioid use and harms that are related to overdose deaths. And this is also impacting young people in Canada as well. Prescription opioids and for non-medical use have been replaced tobacco as the third most common used drug by Ontario teens. Young people ages 15 to 24 are more likely to experience a concurrent disorder, which we'll be discussing further in the webinar. But it is when an individual is living with both an addiction and a mental health related issue than any other age group. Consumption of substances can also start early in the lifespan, and a national survey of grade 7 to 9 students found that about 2/3 had already consumed alcohol. And in addition to that, over 40% of 15 to 19-year-olds have binged on alcohol over the past year. 16% of university students report heavy drinking, and 31% have met the criteria for hazardous drinking. And approximately half of 18 to 19-year-olds have used cannabis in the past year, with approximately 3 to 5% using daily. So these statistics are to provide some context into the rates of use among young people in Canada. Whoops. I'm going to shift gears a little bit here and discuss some of the different classifications of drugs that are currently in the DSM. There's 10, and the most commonly used being alcohol and tobacco. There's also caffeine, which is a new addition to the DSM-5, and that's likely due to an increase in energy drinks with high amounts of caffeine in them, which are frequently used among youth. Cannabis, so that includes any cannabis product, including hash, marijuana, or concentrated edibles. There's some evidence that indicates that young people who are at high risk of developing schizophrenia may experience symptoms earlier if they are frequent cannabis users. Stimulants, so this also includes cocaine or amphetamines, or prescription stimulants that are typically used to treat ADHD, such as Ritalin or Adderall. So these can also be used to increase mental focus and productivity for the purposes of studying, which is an increasing trend that we're seeing among university students in Canada. I'll also note here that the overextended use of some stimulants can lead to drug-induced psychosis as well. So this is acute, and it's usually in combination with not eating or sleeping and lack of overall self-care for an extended period of time. So hallucinogens, which also include LSD or MDMA, also known as Molly. We often see these substances cut with stimulants, especially for party drugs like MDMA. Inhalants, such as nitrous oxide and solvents. Opiates. So opiates are an umbrella term for both natural and synthetic opiates. So opioids refers to synthetic opioids, usually in prescription forms, such as fentanyl, which we've been seeing in the media quite a bit over the past year due to the number of overdose deaths as a result. Oxyneo is also a synthetic opioid, and you'll note that I'm using the term oxyneo instead of OxyContin, and that's because as a result of the oxy crisis that happened in and around 2012, the government changed the name and came out with Oxyneo, which is non-tamper proof, so that means that you can't crush, snort, or inject it. And we're also seeing that prescription opioid use, is increasing among youth, with 13% of young people ages 15 to 19 stating that they have used recreationally over the past year. Sedatives, so this can include benzodiazepines such as Ativan or Xanax, and then other or new psychoactive substances, and I'm going to speak about that in a minute. But before I move on to the next slide, I think it's also important to briefly mention withdrawal symptoms. So withdrawal is often very unpleasant, and symptoms vary depending on numerous different factors, how long someone has used, that sort of thing. So it's often difficult to predict what that might look like for a person. Opioid withdrawals are typically sometimes the most distressing and uncomfortable, but alcohol, because of the possibility of seizures, strokes, or heart attacks, is often considered to be one of the most dangerous substances to be withdrawing from. In addition to that, withdrawal symptoms sometimes take on what's known as the rebound effect. So this is a phenomenon where withdrawal takes on the opposite effect of the drug that has previously been used. So for example, someone who uses cannabis frequently and then stops using it suddenly, they might have problems sleeping, they might get anxious, irritable, or nervous without having that substance. They may have upset stomach or lose their appetite. And you'll note that some of these symptoms are often the opposite effects of using cannabis. Oops. I'm going to speak really briefly to new psychoactive substances, or NPS. So these are substances that mimic the effects of other commonly used substances, but are often synthetic and have a different chemical compound. So they're a new class of drug that may not necessarily be scheduled under the Controlled Drugs and Substances Act because there's a possibility that the legislation hasn't been able to catch up to some of these newer chemicals. So they're often referred to as legal highs or designer drugs, and many perceive these substances to be safe and legal. But what is contained in them might not necessarily be consistent and could potentially be harmful. So they operate in a legal gray area, and because some of the chemicals used in some of these substances are banned in Canada and others are not, it's hard to really know where they stand on the law. That said, though, we do get dozens of new psychoactive substances in Canada annually, and often they can be found in corner stores and in head shops as well. So the photo on the right shows a package of synthetic cannabis, which are widely accessible, and young people are a significant portion of the new psychoactive substance market worldwide. Okay, so what you see here is the continuum of substance use. So most youth experiment with drugs or alcohol as a way to express independence and autonomy, and we know that not all substance use leads to problem use, abuse, or dependency. And a way to sort of assess where a young person is with their use is to look at this continuum of drug use and the stages of substance use model. So this illustration shows how substance misuse can progress. So might start with non-use. So maybe somebody who has never used a particular substance. Or this could also mean somebody who has stopped using a substance, such as somebody abstaining from alcohol after they've identified that they've had a problem. Experimental use. So this might be somebody who tries the substance once or twice, motivated by curiosity. So perhaps a young person who smokes marijuana once, but may not have inhaled it right and want to try to experience those effects again. Recreational or social use. So this is use that's infrequent and irregular, usually on special occasions such as parties or birthdays. And it could be random and may result in binging, say, alcohol at a party, that sort of thing. There's regular daily use as well. So this is when a person has a predictable pattern, and it can be frequent or infrequent, such as drinking a glass of wine with dinner, or someone who might go to parties every month and perhaps have a cigarette with their alcohol. So this user might feel like they are in control of their use and can either take it or leave it. And then there's dependent use or substance use disorder as defined by the DSM-5. So this is regular, predictable, frequent, and it can also range from mild, moderate to severe. So the youth experiences a need for the substance and will continue to use despite adverse consequences such as doing poorly in school or losing interest in hobbies, activities, or people that they used to socialize with. And some users can be in a different stage of use with different substances. So for example, a young person could be dependent on tobacco, a regular user of alcohol, and a social marijuana user. So it completely depends. And it's also important to consider that symptoms of substance misuse can also be episodic as well. So for example, an individual can experience periods of increased substance use as well as periods of control. And we also know that addiction simply isn't just about the substance itself. So it's important to consider the numerous intersecting factors and the ways in which, and also why, a substance is being used. and the factors in that person's life that might make it more desirable than other times to use a certain substance. So as a result, many take a biopsychosocial perspective, which is an understanding that there's rarely ever one fixed reason or one factor as to why someone misuses substances. Often it's some variation of biological, the psychological, and the social. So the biopsychosocial approach essentially allows for all of these to be acknowledged and valid and takes into consideration the complexity and the intersections of all of these different factors. So the biological factor, for example, includes evidence to suggest that some people may be more at risk than others due to their genes and their family histories. Psychological factors can include having a rewarding experience with a substance that encourages a person to repeat that. And there's many aspects of addictive behaviors too, including thoughts and feelings and context that are involved. And it could also include a substance being used as a coping mechanism for pain and for emotional difficulties in their lives. There's also social factors as well. So addictions are strongly shaped by other factors in our lives, such as the social determinants of health. So looking at employment, housing, equity, that sort of thing. Peer factors also help to determine if someone will experience or use a particular substance. And cultural factors, too, also shape what people consider to be acceptable or unacceptable substances, as well as behaviors. So it's also important to ask ourselves what contributes to someone using substances problematically. And there are some risk factors that have been understood to contribute to substance use. And here are some on this slide, and there's absolutely more, but I will focus on these ones today. Some of the risk factors include environmental factors and social factors. So as I mentioned previously, employment, housing, feelings of social inclusion and community. We also know that homeless youth are 11 times more likely to die of a drug overdose. So really taking into consideration some of those social determinants. Conflict in family structure, including parents who use substances as well. Pre-existing mental health concerns, and Ellen will be discussing that shortly. Age. So we know that the earlier in life someone might start using a substance, the more likely they are to become dependent on that substance. Grief and loss, lack of coping techniques, discrimination, impulsivity, and thrill-seeking behaviors, loneliness and isolation, bullying, and trauma or stressful life events. And this is a really important consideration, as we know that there are high rates of people who enter treatment who have had previous experiences with trauma. So approximately 76% of youth with addiction issues have experienced trauma. And it's important to consider these links as we move on to discussing addiction treatment and concurrent disorders as well. The effects of trauma can be both physical and emotional responses, and researchers have identified the broad impacts that can be acute, chronic, or delayed. Because of this, many organizations and clinicians are also working from a trauma-informed model. So trauma-informed care and a trauma-informed model in a program, organization, or system that is trauma-informed realizes the widespread impact of trauma and its links to problematic substance use, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved within the system, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and it also seeks to actively resist re-traumatization by providing opportunities for people to rebuild trust, choice, and control. So I'm going to pass it over to Ellen to speak more about some of the treatment models with addiction and substance misuse and some of the interventions with youth. So.
Okay, perfect. Is this going to be okay if I do?
Mm-hmm.
Okay, awesome. All right. Oops. Okay, thanks, Jean. So that was a really conclusive sort of theory around substance use. So what I want to talk to you right now is about the models, two different models that we use to work with substance use issues. The first model is the medical model, and this model sees addictions as a disease. The person that is engaged in treatment, they have to be ready to quit, so they need to be motivated by this and to abstain from substances. So treatment centers that include this are Alcoholics Anonymous, Narcotics Anonymous, Cocaine Anonymous, and many inpatient treatment centers that requires someone to abstain before they can enter in the treatment program. The other model is called the harm reduction model, and this model focuses on promoting safety and reducing potential harm of people that use substances. So it works on a continuum of treatment strategies that includes abstinence, and it supports people at where they're at. And so it's client-centered, non-judgmental, empowering, and flexible. It helps to reduce stigma of substance users because the substance user can enter treatment at any time, and the person within the harm reduction approach would work with them. So what that could look like is needle exchange programs, drug replacement therapy, drug education around drugs. If a client decides that they want to reduce their use, helping to support that, or if they do choose to continue to use or use, to help them safety plan so that they can use in a safer way. This is actually one of the best practices for youth because it gives them choice. It works with where they're at because youth are in the developmental stage of where they're trying to figure who they are, figuring out their identity. This harm reduction philosophy gives them choice to kind of figure out what their relationship to drugs are and can look like. Both of these models are legitimate, and it is a matter of fit for the client. For example, I had a client that I initially worked with who wanted to reduce their use, and during the treatment, they recognized that they had to abstain because they weren't able to reduce their use in a way that made sense for them. So it's great that the harm reduction model does include abstinence as well. So I wanted to pass it over to Shavik to do a poll question now.
Okay, so Ellen will be has put together a poll for everyone, and I'm just about to launch it right now. So if everybody can participate, we have about we'll set aside about a minute. The question is, why do you think people use substances? And we ask you to select one of the following. The first option is to escape from pain. Second option is to fit in and belong. Third is to cope with stress. Fourth is for boredom. And the fifth option as well is to choose all of the above. Okay, so we'll just give it a few more seconds for everybody to have a chance to go in and submit their answer.
Great, thank you.
All right, we'll be closing the poll in 5 seconds. All right, I'm going to go ahead and close the poll. As we can see from our results, 94% selecting all of the above.
Nice.
3% for to fit in and belong, 3% for to cope with stress, and nobody chose the first option to escape from pain or for boredom. So it seems like there's some consensus there. 94%, all of the above.
Awesome. You guys are all really informed about substance issues. Amazing. Okay, so yeah, definitely. So all of the above is definitely right. People use substances for many reasons, and right now what I'm showing you is not like a conclusive list, but these are some of the reasons. So to escape from pain, to relax, to reduce and manage stress, anxiety, and depression, because they're bored, to feel joy and happiness, to numb out, to feel loved, to fit in, belong, to feel confident, have a self-esteem, to manage physical pain, to feel accepted, and for loneliness. So what if I change this question from why do people use to actually what do people need? So as you can see, it's actually the same checklist as why do people use. So everyone deserves these things to, feel relief from pain, to feel joy, happiness, to feel relaxed, to not feel stress, to feel loved, and to fit in, belong, and feel accepted. So these are some ways that substance user uses substances to meet these needs. So the question actually becomes, is this the only way that they can get these needs met, or are there, in addition to substance use, other ways, or are there alternative ways for them to get these needs met? Because we all need to get these needs met. So these are some of the underlying reasons for why people use, and sometimes people do experience long-term effects from substance use. So we want to explore with them how are some other ways they can now meet their needs. Dr. Gabor Mate, who is a renowned addictions physician who works in the downtown east side of Vancouver, he works with a lot of trauma patients, and he never asks why the addiction, but why the pain. Okay, so now I'm going to switch gears and talk about concurrent disorder. So as Jean said, mental health and substance use issues can coexist, which is identified as a concurrent disorder. People with mental health issues are twice as likely to have substance use issues compared to the general population. At Breakaway, where I work, the top 3 issues that youth uses substances for or are mental health issues, including anxiety, depression, family conflict, and school. Substance use can exacerbate a pre-existing mental health issue, but there is no evidence that it causes a mental health disorder. So a youth may experience drug-induced psychosis from using, say, marijuana, and it may not develop into schizophrenia. However, someone that is at a higher risk of developing schizophrenia, if they have higher risk factors, or it's prevalent in their family, it could exacerbate if they choose to use substances that could mimic, or that could highlight or exacerbate that, like marijuana. Substance use can mask a mental health disorder. So many youth that I see uses marijuana to cope with anxiety and anger. And so oftentimes people may see the marijuana as a problem, but miss that there is an underlying issue of anxiety. And also the youth can miss that too. They may feel that, I'm just using it because I'm bored, but really it's because they have a lot of overwhelming thoughts and feelings. Substance misuse is directly related to self-medication, as you all know, and often substance users self-medicate with drugs instead of antidepressants because it is less stigmatizing. So there are some youth out there that do not want to be labeled as having a mental health issue or disorder, so they may choose to self-medicate with drugs as opposed to going on antidepressants. So now I'm going to actually talk about a tool of intervention that we use. It's a tool to assess where the student or the client is at in terms of their motivation to change a behavior. So right now I'm going to be talking about drug use, but you can use the stages of change for any type of behavioral change. So this was developed by Pacheska and De Clemente. And each stage of change is associated with a distinct set of cognitive, emotional, and behavioral characteristics. And they see, then in the stages of change, they see change as a process. So as you can tell, it is in a circular motion. So that means the client or the student could be at any point of the stage of change in the cycle. So the first stage is pre-contemplation. So this is where the student or the client is not thinking about change. They don't recognize that there is a need for change. And even despite adverse consequences of the behavior, they're in denial of the need to change. So this could look like a student in first year that parties every weekend. They're new to the city, they're in residency, and they really want to get to know people, so they're really partying. And most of the time it could be normal, but then maybe their grades start to decline, they're too hungover to go to classes, but they may not feel like there's any issues with that in this moment. So if there are clinicians out there that are working in a therapeutic context, what you can do is try to really build a relationship with them and really explore what are the functions of the parties and the drug use. So why are you going to the parties? You know, what are you studying in school? What do you like about school? Is this what you kind of thought school would look like? And really understanding, being curious about what's causing them to go to all these parties. Sometimes people that are new to the city could feel social isolation, so wanting to go to parties to make friends is pretty normal. And just another note, youth are usually very defensive and resistant to engage in this stage of change. So really taking it slow and not focusing on the problematic use, but really understanding them and acknowledging where they're at could be helpful. For those of you that are not in the therapeutic context, like if you're in the student union or a John, you can really try to get to know them, build a relationship, find out what their interests are, get them to be linked up to other resources and stuff like that. So the next stage is contemplation. So this is when the client or the student recognizes a problem exists and they are considering change. So the same student may recognize that, yeah, you know, they are hungover a lot of the times, they're missing classes, they're spending too much of their OSAP money on substance use, and they may start to feel like maybe they should make some changes. Youth in this category are typically ambivalent about change, so they may have a desire to change and at the same time don't want to because there's so many benefits of that drug use. So in a therapeutic context, the therapist could kind of do a decisional balance with them, looking at the pros and cons for use, as well as the pros and cons for changing their use. You want to help them increase awareness, discuss where they're at right now versus where they want to be. So is this where they're at right now? Is this their goals or what they imagined university or college would be like? And providing empathy and compassion to them while they're trying to figure out what they would like to do in this process. The next stage is preparation. So this is where the student or the client is getting ready to change. What this could look like is they start a to-do list. Maybe they take away the drugs or alcohol that's in their residence or room. Maybe it's about making a schedule and deciding, you know, I'm not going to use frequently, but maybe I will if I do well in a project and I want to celebrate and use socially. One of the things that I want to highlight is that using substances could be a form of coping for this student or this client. So you always want to try to replace that substance with a different form of coping. So helping them to develop a coping toolkit so that they could have other ways to reduce stress or whatever the reason it is that they're using. And then the next stage is action. So this is where the student or the client is actively changing. So maybe they don't want to use anymore, so they're not using, and they're using other forms of coping, or they've found other ways to reduce social isolation by maybe going to clubs or committees or study groups and stuff like that. And then they'll move into maintenance, where they're adjusting to the change. They're practicing new skills and behaviors to sustain that change. And then at this point, there's one of two things that can happen. Either they will exit the cycle permanently because they've made that change and they're doing well, or they may have a relapse. And what relapse is when someone reverts back to the problematic behavior. And relapse is really an integral part of the change process. Sometimes people, you know, the student may be really stressed out one day, maybe having pressure or blocks to their assignments, and may decide to go party and really fully relapse. That's okay, because at this point, the student may decide, you know, to go back into action stage, kind of see why they've decided to use, take the learning from that, and then continue forth into the cycle. Or they may decide to go back to pre-contemplation or contemplation, and at this point, you would want to start the process again, kind of trying to do the decisional balance, figuring out why they're using and helping to support them to change in that way. Yeah, so one thing I wanted to also note is that someone could be on different stages of change with different substances. So for a polysubstance user, someone could be in denial about their alcohol use, but actively changing their marijuana use. So finally, I wanted to talk to you a little bit about engagement. This is an acronym that we use at Breakaway called CLEAR, and this is just a way of approaching the student or the client. The first thing is having curiosity, so asking questions, understanding their biopsychosocial model, the context of which they're in school, what's their struggles, what's their strengths, really looking at a full picture of who they are. Listening to them, having empathy, putting yourselves in their shoes and understanding where they're coming from. Acceptance is another one. So oftentimes people ask me, does acceptance mean I'm condoning the behavior? It doesn't mean that at all. It means just really acknowledging where they're at in this moment, and that maybe, the reason that maybe they can't change the behavior is because there's other factors like trauma and other things involved, and it makes it very complicated. And then also respect, and I'm sure no one has any issues with that. Yeah, so this is concludes the presentation. Both Jean and I developed a resource and further readings list for you guys. We did cover a lot of information, so if you wanted to do some further reading on youth and addictions, we have these links for you and these books that you can read and learn more about youth and addictions. So I'm going to turn it back over to you, Shafiq, because I think you're going to do the Q&A period.
Yes, so we will definitely get into the Q&A period very soon. So I would ask the attendees of the webinar to go ahead and submit your questions right now, and we will get started on the Q&A in a few moments. So while people are populating the questions, I just wanted to ask a couple follow-up questions to both Jean and Ellen, specifically around the trauma-informed practices. I'm
Sure.
very curious to hear a little bit more in terms of when this started to become a more commonly used understanding to be able to address issues around addiction, and what the impact has been in terms of actually incorporating this trauma-informed practice.
Yeah, that's a great question. I mean, it's common knowledge, really, that there are intersections between trauma and addiction and substance misuse. However, the idea of trauma-informed care is a relatively new concept. Previously, I was employed with the Jean Tweed Center, and if you'll notice here, there's Trauma-Informed Practices manual that was developed by them called Trauma Matters that came out a few years ago, and it's a really helpful resource in sort of understanding some of the links, especially for people that are working with women, because we do know that the rates of women who are entering treatment who have past experiences of trauma are much higher than men. And it really is a way to provide a safe, and when I say safe, I mean both physically safe and emotionally safe environment for people to make the connections between their substance use and previous experiences. And so really taking a look at some alternative coping techniques, both for the trauma and for the substance use as well. And so really, one of the first sort of steps of that is what we call psychoeducation, which is allowing and providing information around some of those links, and as Ellen was mentioning as well, some of the concurrent disorders that can occur with addiction and substance misuse as well. So that's one of the major pieces, right, is helping and assisting somebody to make those connections on their own. And I don't know, what do you have anything to contribute around trauma-informed care?
Yeah, I mean, I think what you said is really valuable, definitely. For us, I think we at Breakaway we see the trauma-informed care as having flexibility for youth. So that could be, you know, youth may not say come on time, or they sometimes may not show up. They may cancel last minute. That could be very trauma-related, based on maybe a fear of, you know, coming in and sharing abandonment, or just opening up, attaching to someone, building a relationship. Could be very difficult for someone that may have attachment issues related to trauma, or caregivers that's hurt them, and stuff like that. So instead of having a blanket statement of, you know, you can't ever come in again, I'm gonna stop giving you service, really I would dissect that with them, you know, give them sort of flexibility around that. So that's one way of kind of how we've used trauma-informed practices at our center with youth. Yeah, so there's sort of many strategies, but certainly under having flexibility and understanding why they may not be doing things that, say, a typical youth that hasn't experienced trauma is doing is helpful.
Yeah, I think that's a really great example too, and to approach it from a non-judgmental place that sort of explores it with compassion and curiosity. So, for example, to say something along the lines of, you know, I noticed that you're maybe not coming to appointments as they're scheduled, or you're, you know, frequently coming up late. Maybe what's behind that? What do you think is behind that? Is there anything that I can do to support you in meeting what your goals are? Because you obviously want to engage in this process, and to sort of yeah, approach it from a way of sort of mutual understanding, and being able to connect from there. And really establishing a space that allows for choice and control, because as we know, people who have previous experiences of trauma may not have experienced that. So to really provide that supportive space where you can work together to meet some of those goals that they might have.
Okay, thank you. And I have another question, specifically around the slide in which you indicated the various approaches, one using the medical model and the other one using the harm reduction model. So I'm curious if somebody, and it was very interesting for me to hear from you that you know, both approaches are legitimate, but we have to be able to find out which one is the best fit for the person that we're supporting. Now, in your experience, how have you gone about trying to determine which one of those approaches would be appropriate for your client?
So Shafiq, that's a really great question. So with every client that comes into Breakaway, we do an assessment with them. So we do what Jean has mentioned around the continuum of substance use, sort of assessing how problematic their use is. We also kind of talk to the client. We make it very, very collaborative. So looking at, you know, where are you at? Like, do you want to, like, let's look at the pattern of your use. Let's look at the function of it. Are you engaged in some really risky behaviors? Are you experiencing some really, you know, big consequences, like maybe the person's being charged, or maybe, you know, they're about to get on academic probation, or withdrawn from school. So we want to look at, you know, is this where you want to be, and where do you want to go? Kind of look at their future goals, and then kind of assess with them if inpatient treatment or a medical model is more appropriate, or if they want to maybe do some outpatient harm reduction stuff and then move towards inpatient treatment. So it's really collaborative. We try to make it that way. We look at the stages of the continuum of substance use, as well as the stage of change. So we want to kind of look at their motivation level. So someone that's in an action stage of change and their independency of use may really benefit from an inpatient treatment, as opposed to someone that is contemplative, meaning they're very ambivalent, they want to do it, but they're really scared to go to inpatient. Then we may want to do some more exploration to support them if they eventually want to get there. So yeah. Jen, do you have anything else to add?
Yeah, I think that, you know, the role of clinicians is to support, right? And so, you know, people know what's best for them, and our role is to identify with them what their goals might be, and if their goals are complete abstinence, okay, how do you go about supporting that? providing various different options and allowing them to make an informed decision. If the goal isn't abstinence, okay, what can we do to reduce or mitigate some of the harms that might be happening for you in this moment? And some people might not identify that there's harm, some people might, right? And again, it goes back to those stages of change and where someone might be in that process. But again, as Ellen mentioned, it really is a collaborative approach, and it completely depends on where someone is at and what their goals are, and what can we do to support and to assist in the person achieving some of those goals. And it's also a matter of trial and error, right? So some people, might try out a certain group or a certain way of counseling, or go one route and realize that it's not for them and try something else, and that's completely normal. And yeah, it really is a matter of just sort of supporting them where they are at and what's the best fit for them.
Okay, thank you very much. So let's move on to our questions from our attendees. We have a couple questions so far. So the first question is from Kate Humphreys, and she's asking, what is the most effective way to open a discussion about bootleg fentanyl with someone who is a non-regular user or a party user?
That is a great question. And I'm really glad that you asked that, because we do know that there are some really significant risks around opioids, especially with fentanyl, because there are a number of different substances that are found to contain fentanyl now. So I really appreciate that question, and I think it's a really important topic of conversation. And I think it's also really complex too. I think one of the most important things is providing people with as much information as possible. And that is sort of what we know is incredibly effective with the harm reduction perspective. So providing people with as much information as possible in order for them to be able to make informed decisions about what's best for them. And that can be difficult sometimes as someone who is a support person, because we know that there are really significant risks, especially around what's happening with fentanyl currently. So I would suggest, really arming yourself with as much knowledge as possible about what's going on and what some of the potential risks are, providing yourself with, or obtaining as many resources as possible, excuse me, and then sharing it with that person and saying, this is a concern, and here are some resources. How can I support you to meet some of your goals around keeping yourself safe and mitigating some of those harms? I don't know, do you have any suggestions around that? Again, great question.
Yeah, that is a great question, and Jean, I think you did a great job answering. Definitely, the psychoeducation piece is really important, helping them to make an informed choice, and for you, knowing what's going on is really helpful. Definitely, I would always try to encourage my client or the youth to do their own research so that they feel empowered to be able to learn about what the effects are. There are a lot of great websites that talk about different strategies that you can use. For example, I may talk to the youth about if they want to use carfentanil or any other type of substances, to make sure that they access a trusted drug dealer that they know, to make sure that if they are trying something new, that they kind of look at it and inspect it, and maybe if they are going to use it, be with a supportive friend, be in an environment that's safe, so that it's that they don't feel like they're not in an unsafe physical space. Make sure that they've eaten, yes. Start low and go slow. So I know sometimes when people hear this, it's like, oh my God, are we condoning this? Are we encouraging this? The truth is that if a youth is going to do it, if they're choosing to do it, they're gonna do it, and we can either be a support to them, as Jean said, or we we may be another person that they can't trust. And a lot of times youth and students don't experience trusting relationships with adults. So if this is a person that is coming to you and talking to you about this, it's really great that you can start a dialogue with them and open their awareness up to the potential risks and potential safety plans that they can do to ensure as much safety as possible.
Great. Yeah, and in addition to that too, I think it's also really important to mention naloxone. So in June of this past year, Ontario made naloxone, which is an opioid antidote, so it reverses the effects of opioid overdoses, free and available at every pharmacy across Ontario. And I think that it's really, really important to say that and to let people know that naloxone is something that you can pick up. There are some pharmacies that haven't necessarily worked out their policies, but that said, they are easily accessible. So if you go into one pharmacy, they don't have it, or there's some confusion, go down the street and check out another one. It's a really important tool, and if you are working with youth that are using opiates, I think that it is a really important thing to know how to use and to have one on site, and to encourage the people that you're working with to also do the same.
Yeah, and one other thing I want to add, Jean, is maybe helping them to explore what overdose looks like, so that they can maybe tell if that's happening to them or to their friends, and then being able to support them to get this kit, or some other strategies like call 911 if they can't get the kit right away.
Great question.
And, in terms of the naloxone kits that are available at any pharmacy across the province, do the staff at community agencies as well as the colleges and universities have the ability to have some on hand?
Great question.
Yeah, that's a great question, and I think that it would probably depend on the policy of the institution. Because it is relatively new, and when I say relatively new, I mean being accessible, like I said, as of June of this past year. I think that there's a lot of changes that are happening in terms of knowing that that opioid overdose is a significant risk, and there are harm reduction steps that can be taken to lessen some of those risks, including having naloxone. I know there are a lot of, especially in Toronto, some community-based organizations that do have that on site, but unfortunately I can't speak to what's happening within a university setting, and I think it would likely depend on the policies of specific institutions.
Yes, it's very likely for it to vary from school to school, and the fact that it has come around since just June of last year means that hopefully there probably will be some progress in being able to have those types of resources available, and even potentially in the future some education around how to actually use one of those kits.
Yeah, sorry to interrupt, but there are organizations, for example, some Shoppers Drug Smarts, that will train clinicians or even staff if there are policies allowing that in universities and college. They do have training free for people that want to learn how to do it.
Excellent. Well, thank you for that.
Yeah, so and just to say that the kits are called naloxone, also sometimes referred to as Narcan.
Yes.
Okay. And we have another question. This is from Alan Fine, who is actually part of Mental Health Innovation Fund project. He works at McMaster University for the Arrive and Thrive project. So he's saying one of our trial programs is called Pause, and includes an up to a 90-minute single session with a person who is interested in exploring their alcohol, tobacco, or marijuana use. One of the interesting challenges they have found is for students in pre-contemplation who we engage with around marijuana use see very little negative consequences of their use, even if it is directly impacting their time at the university. In your experiences, how would you frame a conversation for students who don't want to change but maybe should start thinking about making a change?
Great question. Yeah.
Yeah, that is a really great question, and pre-contemplative is a really challenging stage to be in, especially for like a clinician or a frontline worker that is working with a student, because their grades are falling, and the clinician identifies that there is a problem. But unfortunately, what I can share with you is that the only thing you can do is really to maybe poke some holes in their perception. So maybe look at, okay, well, if you don't think that there is a problem, what do you think is causing some issues, like maybe with motivation or concentration, or for your grades being this way or whatnot? What do you think it is? And if it isn't the marijuana use, could it be a combination of the three? Because mixing could be it could really impact the brain and the chemistry, and maybe explore kind of like a bigger picture place, because maybe a lot of times youth are kind of stuck in this hyper-focused place of, oh, nothing is wrong, I'm just having fun. So maybe you want to start to be curious around, okay, well, if you could stop, how would you do it? You know, are you just having fun right now? And you know, what are some reasons for why you're using? So really kind of being curious and exploring. I don't think there is a right or wrong answer, but a big thing is to develop a relationship with them so that you can leverage that relationship when they start to see, oh, okay, right, maybe I am starting to see that I have a problem.
Yeah.
Do you want to add anything else?
Yeah, it sounds like a really terrific program. And it sounds like it's a really great step for people who, again, are in that pre-contemplation stage. And it's always interesting to me that when you have a service like that that's available, people use it, right? And so it sounds to me like they're engaging with that service. It's obviously something that they want to talk about. They might not be in a stage to necessarily make changes in that moment, but it is something that they are considering. Yeah, so something that you say, something that you share that day, you know, might potentially down the road contribute to making changes in the future. And again, just on the psychoeducation piece, it's really a matter of sort of having as much information as possible that you can provide and ensure that they are able to make the best choice based on whatever their needs and their goals are. I hope that's helpful. I'm not sure, but yeah, it's a great question, and it can be, you know, difficult to work with people at that stage for sure.
Yeah, and I think, Jane, you mentioned a really great point, is that if they're engaged in the program or that 90-minute session, there's a reason that they're there.
Yeah.
And they may not identify substances as an issue, even though the clinician's like, oh yeah, that's definitely 100% the issue. But maybe you can sort of collaboratively ask them, so what brings you here? Like, is it really the addiction, or is it the drug use, or maybe it's something else? And then kind of develop your relationship through that other thing, so that they could start to look at their drug use in a different way if your service allows for that.
Yeah, great point.
Okay, great. So thank you very much, Jean and Ellen, for presenting on this topic today. There was definitely some very interesting and useful information that I feel would be you know, very effective to understand once we're actually in the field and supporting students directly. So we are coming up to the end of our webinar, so I will just reassert the fact that there will be a survey that will pop up once the webinar has come to an end. So I'll please ask everybody to please submit their feedback for our webinar today, as well as outlining the fact that there will be a recording available of this webinar as well. We should have it up in the next couple days on our website, so you can visit us at campusmentalhealth.ca, and there's a section for our webinars in which we have an archive this webinar, as well as all the other previous webinars that we've done in the last few years. I will also say that there are other aspects of being able to get involved with the center. Just to make sure that you are on our emailing list, when you go on our homepage, there is the ability to go ahead and add yourself so we get all these updates, as well as understand there's going to be another upcoming webinar, and that will be focused on being able to provide mental health supports and services to our LGBTQ plus youth population in our colleges and universities. So I want to thank our presenters once again, and thank to all of our attendees for participating in this webinar, and everybody have a great day.
Great. Thanks very much.